Yes, I can
Okay.
see.
Okay. So we are glad to share our experience to the facility registry community, and also learn from the community on how to also improve our activities in the country. So before starting my presentation, even if some of you are well aware about what's going on in Ethiopia, I would like to just give you highlight about the some facts about the country, which will help us to understand how large it is managing health facilities in the country. As you can see here, Ethiopia is one of the 10 largest country in Africa, and it has 10 regions and 2 city administration. And there are more than 22 or 21,000 public health facilities. Here I mentioned public health facilities, and there are more than this number of private facilities also. From this, more than 17,000 are health posts, which are found in more rural areas. And there are also more than 3,000 health centers and 385 health hospitals. So having this highlight about the country, I would like to present my presentation in 2 parts. First part will be how our MFR journey looks like. And in the second part, I will go fast on how we use the GOFAR Global Open Facility Reconciliation Tool to reconcile facility list and align the data with geospatial data. So in the first part, I will discuss what are the challenges regarding to the MFR system and what are the opportunities that we have. And I will briefly highlight the MFR development process and how MFR used in the e-health architecture, Ethiopian e-health architecture, and how it looks like management in the government structures look like, and lesson learned. So as you know, the facility registry or a facility list is one of the key lists in the health sector. So it will be helpful for planning health systems, facilities, and also investments. And also it is an important list to have optimizing health facilities across the country. So if we don't have this facility list, it is very difficult to manage investments and also implement and improve the health sector. And there is also a challenge of duplicative list of facilities from different stakeholders. And also we, in emergency cases or in disease outbreaks, it is very difficult to have the list of facility list. Like in the case of COVID-19 response, it is very important to locate facilities and resources so that emergency responses should be very approved. So we also lack open data sources for the public or for the third party to have additional, to value added additional resources. So these are the challenges. So once the MFR will address these issues and additional challenges also. So the opportunities that we have in the country is the e-health architecture is widely acceptable from the management side. And this gives us opportunity because MFR is one of the key shared service, foundational service in the architecture. So it has to be there, it has to be developed. And also there are existing lists that are available in the DHIS2 or other sources. So this is also helpful to populate the facility registry. And there is also a clear procedure of health facility registration and licensing. So facilities need to be recorded in the database to finalize the registration and licensing procedure. So this is also an opportunity to enforce those facilities that are not registered And there is also technology advancement in the last few years, which is related to standards. And we will also use best practices in implementing technology to support the master facility record. So we use all these opportunities to improve our facility record. As a similar health information system implementation, the MFR follows these development processes. That means there is a technical working group under the Ministry of Health, which works closely with partners to document requirements and user stories, like what are the basic curation processes, how it is used in the interoperability and data exchange requirements. These documents are recorded, and then different stakeholders because they are the consumer of these MFR systems, like the ministry, regional health bureau, agencies, partners, research institutes are also consumer of this system. So we need to know how they are using the system, what kind of data sharing and using the facility for different purpose. So we also analyze these stakeholders' interest in this development process. And initially, before MFR matures, there are different existing data sources in the ministry, like the Service Provision Assessment Survey. DHIS2 have its own facility records. So we used these data sources initially to populate the master facility record. And there are two major domains for the attributes of facilities. We have the signature domain, which consists of 14 data elements, which includes like facility name, contact information, geospatial location, and unique ID, and also service domain information, which is related to infrastructure, basic service like water, electricity, ICT infrastructure, and also human resources. So initially, the MFR use these existing data sources to populate and follow the standard domain data attributes in the system. So the first version of the MFR that was implemented, and currently it's we have the first upgrading to the new version. And the first version uses a backend technology, which is based on a resource map. And this is a backend, and at the front end, we have Angular-based system, which is used for user management and data curation. And we upgraded to a HappyFire backend with this without changing the front end, because it will be a good approach to not for those who take the training. They don't feel that the MFR system is changed, because the front end is the same, but the back end is the one we are currently upgrading to the HappyFire. We have different reasons for doing that. The first one is we have a performance issue on the system on the previous version, which is very difficult for data curators to populate the data. And the other one is the technology trends and data standards. And we also go along with current technologies on interoperability and messaging standard and planning to use the FHIR. So this also helps us to move to the next upgrade, the next version. And we also have basic technical skills on Java, which is we have a number of technical expertise on this part, so that we can have we don't have any technical issues on the new version. And we have also other different HIS applications that are using the backend technology, which is based on FHIR, like the IHRS system. So these are the major reasons that are used for upgrading the current version of the system. So to just to give you a highlight about how the MFR and is used in the e-health architecture of Ethiopia, as you can see in the picture, the MFR, the Master Facility Record, is one of the core services in the shared service. So based on the e-health architecture principles and guidelines, we are implementing two interoperability solutions based on MFR. The first one is MFR to DHIS2 interoperability. As you can see here on the sequence diagram, we have the master facility card and we have a middleware based on OpenHIE. So we also tested this workflow on a test server, and now currently we are finalizing this testing based on the upgraded version of MFR. So most probably by the end of next month, we will go live once MFR is fully operational. So as you can see here, we have a flowchart diagram. We have different use cases, more than 14 use cases that are implemented in this workflow. So the MFR is a key data source for DHIS2 system. The other data interoperability solutions that we are currently doing is data exchange between electronic community health information system, which is used by thousands of health extension workers in a rural area to collect health data from family at the family level. So this data will be aggregated and compiled and directly populated into the DHIS2 system. We used two shared services, MFR and the terminology service, Open Concept Lab, to communicate and exchange data based on the e-health architecture principles. In this case, we don't directly integrate ECHS to DHIS2. As you can see in the picture, we used shared services, and one of the shared services, MFR. So we are also finished testing this on different maternal and child care data elements, and we are in the process of implementing on demonstration site in this by the end of this month. So as you can see here, MFR is also used in the e-health architecture. In addition to serving as a master facility list, it is also used as a source for different health information systems in the health information ecosystem. When we come to the MFR management and governance, this helps us to ensure a smooth implementation of the MFR system, because MFR is implementing MFR is a very huge task because of the large area that has to be addressed and large number of health facilities, and also the challenges is in a low resource setting. We followed a team-based approach. That means we don't create a new structure in the ministry and at the regional level. What we followed was to assign roles and responsibilities within existing MOH structure. So we identify different responsibilities and assign different team so that they follow these responsibilities. Like as you can see in the table, there are three main directorates in the Ministry of Health: the HITD department, which is responsible for technology and upgrading the system and capacity building also. And the policy and plan monitoring evaluation is mainly focused on data requirements, data approval, user management, and other all management. And the health and health-related and regulatory directorate is the one which is currently responsible for managing the MFR implementation. So it mainly focused on data curation and also providing license and following regulation, whether facilities are registered in the MFR or not. And the MFR governance, as you see on the organization structure, it is also has this organization structure. One of our challenge is this organization structure is not fully implemented in the MOH, in the Ministry of Health. As I will mention in the lesson learned, one of the reason is there are other competing priorities, and they are focusing on other the systems and other developments. So data curation and more on data curation and approval took some time. So maybe this is due to one of the challenges, the backend systems that we currently upgraded. So we hope the upgraded version will have a better performance. So this can be solved, but the organization structure, as you can see here, there is a technical working group. Currently, they are meeting bi-weekly. If there are some issues now, it will present it to the technical working group, and if it is beyond that, it will go to the IR steering committee or other national advisory group. So in order to also to operate and maintain the procedures, there are flowcharts. These flowcharts will be used as a guideline to maintain and operate day-to-day operation of the MFR system. As you can see in this example, we create a flowchart for how to add a new facility into the MFR system. So as you can see here, the regulatory directorate plays a major role on first checking the regulatory criteria are fulfilled or not. Then it will populate the MFR data to some extent, and then the other M&D department will continue on approval of the system. So the system has a public site and also a backend site, and there is also currently limited information is available for the public, but depending on the policies and guidelines, some data might be available for the public, but it can be accessible for following this URL. And currently there are around 52,066.81, but this data includes those with at draft level and pending level. So when there is also another approved level, the approved level might be a bit less than this number. So the upgraded version will have the correct number of data. So lesson learned from this process, we learned that this is a very resource-intensive initiative. When you say resource, it might be also budget or time, and also needs a number of trainings and capacity buildings have been given at the Warada level, at the low level of the administration hierarchy. And we also have learned that since MFR have a number of data consumers, we have to make sure that there is a balance between basic data requirements. Like some directorates might want to add some data attributes to the facility. And if we just accept that request, then the MFR data will be extended to a very large amount of data attributes, and it's very difficult to maintain the data. So we keep a minimum basic data requirement, especially for the signatory domain. And there is also a significant improvement acceptance from the higher management on the importance of the system, because as you can see, as you can know, MFR is like, if you don't immediately use the system, mostly it's used for other systems. It runs in the background most of the time, so it lacks visibility But currently, due to the acceptance, improved acceptance of the e-health architecture, the shared services are now getting more noticed from management. That will also a big contribution for our effort. And there is a need to design a sustainability for a sustainability model, especially for keeping up to date service domains to document and maintain service domains of facility. So we need to identify sustainability models, as well as we can learn from the community if there are any kind of incentive mechanisms to make sure that quality data has to be maintained and up to date. And this is also a work in progress. We are still learning from the process, even if it is implemented a few years back, but it's a learning process. So these are the main journeys from our implementation of MFR in the country. Shall I continue, or shall I finish it and be ready for the question and answer?
I would love for you to continue, but do people have any questions? Maybe we can take one question about the first part of the presentation, which is really the overall implementation, before Nebyou gets into the facility reconciliation process. Any questions?
Hey, Nebyou, this is Adam. Thanks so much. I just have a quick question for you. I noticed that you had OpenHIM included in many of these diagrams. I was just curious, the use of that across other areas. I mean, it's being used here to synchronize data between the MFR and DHIS2 in this case, but do you know of other use cases for that, other ways in which that middleware service is being used?
Yes, let me go back to one of the slides that we use here. We also used the OpenHIM during the ECHS DHIS2 integration here. So one of the use cases that we use is, like, for example, if there is aggregated data element that come from ECHS, but that data element should have to populate to the national HMIS system. So as you can see on the web sequence diagram, first it will check the MFR, so that facility names have to be aligned with that from ECHS and DHIS2. And then also there is OCL, the Open Concept Lab. It will check the data values mapping. So this is another use case for implementing OpenHIM in addition to MFR to DHIS2.
Great, thank you. Thank you for pointing that out. Thanks.
Thanks. And maybe so please go ahead, Nebyou, and then we'll hold the rest of the questions till the end. I will just encourage I know we have one or two folks that work in different countries or represent a few other countries that are embarking on integrating a facility registry. So it would be great to get you to share maybe some questions with Nebyou once he's finished, specifically on some of the challenges that Ethiopia encountered, which I think will be very helpful in your journey as well. All right, but Nebyou, please go ahead.
Okay, thank you. So as I mentioned in the first part, the initial data populated on the MFR system came from DHIS2 and service from different surveys. So one of the challenges that we faced was this information. Most of the information lacks geographic geospatial data, which is critical in data analysis, particularly for health facility mapping and optimization activities in the ministry. And collecting this GIS data is very expensive. and also it's time taking. And there are a number of efforts that has been made to collect and put this geospatial data in the MFR system. So the challenge was we have a master facility list in the MFR, but most of them are lacking this data. So recently there are different efforts have been made at the ministry level to collect this data. And there are some data sources that come from the Central Statistical Authority, the Ethiopian Statistical Authority, that was collected in their different activities. And there are also data sources that we collect from the Ethiopian Public Health Institute and other sources. But the challenge is here, since these data sources have different facility names that not aligned with the MFR system, where we had a very difficult very difficult situation. So what we did was we explored and found a tool named Global Facility Reconciliation Tool, which we are used in a workshop of setup to map facility names first, based on their administrative hierarchies. And we used a phase-based approach because there are a lot of facilities collected that includes public, private, and non-government organization. So first we focused on those public facilities, hospitals, health centers, and posts. And then after learning this process, we will plan to implement the phase 2, which consists of private pharmacies and like drugstores and as warehouses and other facilities, health facilities. So as you can see here, we used a workshop setup, which came from different stakeholders. So we map this data based on this tool. So this is a very interesting tool, which I used to automatically align some facilities and also suggest based on algorithm. So manually we intervene and try to match these facilities. So as you can see here, we have a very good matching statistics here. So on average, it is around 87% average have already matched with geospatial data. So the one region is way below from other regions. This might be because of quality data not coming from that region. So overall, we have a very encouraging results to match data using the facility record based on facility name and also geospatial data. So lesson learned from this exercise is the methodology will help us to, it's a reputable methodology, and using the GoFar tool, we can also reconcile private and non-government health facilities. This will help us to enrich the MFR registry to have a better quality, and also helps to provide geospatial data analysis for better decision making, and ultimately it will also improve the data use in the country. So this is, I think, a short presentation, but I can answer if you have any other question. Thank you all.